Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
An advanced endoscopy. What in the world does that mean? So we are talking to this evening about advanced endoscopy continues to improve, and specifically, what is it that continues to improve right here in the borderland, right here in El Paso? You may guess that this has to do with digestive orders. It's going in this side and it's going in the other side, but there's all kinds of new things that are happening. Yes, it's dinner table discussion, because nowadays you just got to talk about things that are uncomfortable, because that makes you more apt to ask your doctor specific questions. During this next hour, we have experts again answering questions about advanced endoscopy and how it continues to improve. As you know, it's a live show, so give us a call at 881-0013. This evening's program is underwritten by the University Medical Center of El Paso. We also want to thank the Texas Tech Paul L. Foster School of Medicine for providing medical students with us. And today we have Karen Vaz with us, and she has really good handwriting, which is beautifully helpful for me. Karen, if you can wave to her audience. So this is the young lady who is going to be answering the phones to you. And Karen, can you hear me? What year student are you? She's a third-year student, so she knows her stuff. So by all means, call in, and Karen will get those questions our way. Again, that number is 881-0013. I also want to say a huge thank you to the El Paso County Medical Society, who brings the show to you each and every month, several times a month. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Hi again. We have one veteran with us this evening. You may recognize Dr. Ladd, but before I officially introduce Dr. Ladd, we have Dr. Cesar Garcia, who is at University Medical Center of El Paso. He is gastroenterology and advanced endoscopy. So that's important. That's what we're going to be speaking about tonight. It's very much about advanced endoscopy. We also have Dr. Sharif El Hanafi. And we talked about where the accent goes on his name. Texas Tech University Health Sciences Center of El Paso. He's an assistant professor, and he's with the Division of Gastroenterology, Advanced Endoscopy, once again. And we have Dr. Antonio Mendoza Ladd, who's been here several times before. Thanks again for joining us. He's the one that provided the great videos that we're going to be watching this evening. He is Texas Tech University Health Sciences Center of El Paso, assistant professor, also Division of Gastroenterology, Advanced Endoscopy, and he's the medical director of the University Medical Center Endoscopy Department. So that's a big deal. Say that 20 times, right? That's a lot to talk about. But I just talked about Dr. Garcia, Dr. El Hafani, and also Dr. Ladd. I gave a brief explanation to our audience as to what you guys do. But it's better coming from you, because you all have slightly different paths of what you do all day, every day. So Dr. Garcia, if we can start with you, 30 seconds, a minute, minute and a half, however, describe to the folks at home what it is that you do all day, every day.
When we talk about endoscopy, people usually, the first thing that comes to our mind is colonoscopy for early diagnosis and prevention of colon cancer, upper endoscopy for the evaluation of common GI conditions or gastrointestinal conditions like heartburn or abdominal pain. We also do, besides those procedures, advanced endoscopy. What is advanced endoscopy? Is when we use special technology and equipment to manage more complex gastrointestinal cases. So, for example, we do endoscopic ultrasound. That is, instead of doing ultrasound from outside the body, we do it from inside the body. We do ERCP that we're going to explain in detail later on what is this about, but we can manage cameras and devices or accessories through the biliary or pancreatic duct. We can remove very large polyps. In this way, we prevent those polyps to become cancerous, or even sometimes those polyps have like focal, or what we call carcinoma in situ, and we cure patients from cancer with just an endoscopic procedure. We also are very preventive in case of patients with Barrett's esophagus. We try to diagnose dysplasia as early as we can. There is a few steps before these patients develop cancer, and we are proactive burning those areas of dysplasia in order to decrease the chance of these patients developing cancer as much as we can.
So
with
you're
the
looking at
current
an
technology.
interventional approach, so to speak, like almost a preventative interventional approach if there are symptoms, if there are things to look for.
Correct. It's both. I mean, in advanced endoscopy, we also, besides the preventive areas, we also, when patients have cancer, we can do local staging. We can do more complex procedures like drainage of fluid collections. We also can, patients when they are obstructing, let's say that they have a tumor at the end of the stomach, they cannot pass any food. We have one of the expert in Texas here, and then he's going to show one of his videos putting a stent, everything through the mouth, and
Right.
putting a stent directly from the stomach to the small intestine. That is going to give good quality of life to this patient in this stage.
Exactly, and that's beautifully explained. So we do have, just kind of in the back of your mind this evening, we do have a couple of videos that we're going to show this evening. I love videos. I love the graphics because if you have a queasy stomach, just look with one eye if you need to. But to me, it really helps describe what is happening, what the doctors are looking for, what it is that you are describing as any type of symptom, so to speak. So Dr. El Hafani, if I say it wrong, stop me.
الحنفي.
Hanafi. El Hanafi. So let's talk about what you do all day, every day. And I know that you've given us some slides that we're going to look at later. And again, so I'm going to look at you as futuristic
Sure.
guy. Because on every show, it's very important to me that we get across what is on the horizon.
Absolutely.
And if we're talking about in advanced endoscopy this evening, it's already what's here, but also what's coming up.
Absolutely.
So we're going to talk a little bit about that, but right now, how would you describe yourself to the audience?
So I am a gastroenterologist who had more training, advanced training in advanced endoscopy, which require extra training in advanced endoscopy. So what we do what's called minimally invasive procedures. So it is like small surgery or minor surgeries. It is like not open surgery, but we are trying to avoid people to go to surgery.
Right.
So,
Beautiful. That's
so
good.
this is plus we do general endoscopy like colonoscopy and endoscopy, but because there is certain expertise needed for advanced endoscopy, we here in El Paso, so we were able to get more training and do this advanced endoscopy procedures. So I am the most recent member of the group, and it is wonderful group. We work together. I do most of the procedure done by Dr. Garcia and Dr. Ladd, and work together, discuss together. We work in multidisciplinary fashion. So we do almost everything, and we try to help people who has to diagnose cancer, prevent cancer, and sometimes we treat early cancer.
So I want to focus on, when you're saying that, so I want to focus later just as the show progresses. So preventing cancer, focusing on, again, I know this is not screening per se. When we're talking colonoscopies, it's screening, but when we're talking about endoscopy going through the mouth, it's not always necessarily screening.
Absolutely.
However, I know that there are some new things on the horizon actually occurring right now
Yep.
too. So as I speak some of these questions or ask some of these questions, kind of think about that too, of what we're looking at as far as prevention.
Absolutely.
Prevention's the wrong word. Early detection is probably the right word at that
Yeah,
point.
and prevention
So,
as well.
and prevention too.
Yeah.
Well, good. Then we'll talk about
Yeah.
that as well. Dr. Ladd, superstar. Sorry, I've had him on several times, and every time I learn something brand new that I feel like, oh, I got this, because it's the audience knows. I do my research. I feel like, oh, I'm going to go in. I know what I'm talking about. There's always something like, really? I had no idea. On that note, really? I had no idea. What are you doing now that was different from the last time you were here? And I say that because I know that in a year, everything can change when it comes to techniques and procedures, etc.
Okay, well, thank you for the invitation again. We appreciate being here. I don't think I'm doing anything different than I was doing last year. However, we have a timeline and a plan. Probably in the course of this year, we're going to start a new line of service in the endoscopy unit, which is called a submucosal endoscopy, and we can talk about it a little bit later. I guess when we talk about advanced endoscopy, endoscopy has evolved from a purely diagnostic tool that was invented back in the 50s when the first flexible endoscope was developed, and we were able to put it inside the mouth and the colon, to a more therapeutic procedure. When we talk therapeutic, we're talking about someone gets a regular screening colonoscopy and they find a large polyp. 20 years ago, that patient probably should have gone or would have gone to a surgery. Nowadays, we're able to remove those polyps with the endoscopy, and we save the patient a surgery.
Right.
We do endoscopic ultrasound, like Dr. Garcia said, to stage or know how far in the process a tumor may be, anywhere in the stomach, the esophagus, the colon, different parts of the body. We can actually remove full tumors nowadays. It requires certain expertise and certain tools.
And that's where the advanced portion of endoscopy comes in.
Yeah, advanced endoscopy is, I guess, another word to say just therapeutic endoscopy, because it really has, most of it, we focus on the therapeutic aspect of it. That way, someone has a lesion that, again, years ago would have gone to surgery, now we're able to remove it safely and effectively with an endoscopy. And obviously, that's what it's all about. And we're constantly working with the industry. There's a lot of research that goes on in this field. There's always improvement in techniques, in the devices, and the cameras that we use. We're able to find polyps as small as 1 millimeter now that maybe 10 years ago we were not able to see it.
Right. Okay.
Because the optics of the cameras have improved so much. And there's always, like I said, it's a very constantly evolving field.
Right. So Dr. Garcia, I'm going to kind of start with you. Dr. Ladd kind of explained a little bit. We do several shows here and there about colonoscopy, so I feel like if there are people that are tuning in often, they know a lot about that. So let's try to focus this evening on the upper part of the respiratory digestive system period. Myself, I went to a dental appointment, just a dental cleaning, and I had a polyp on the back of my tonsil. Never thought that was a thing. Why is that a thing? I mean, beautifully they were able to do a partial tonsillectomy. It was done. But again, the polyps, we think about polyps associated with the colon, but we don't think about polyps in the back of our mouths, in our throats, going down the esophagus, going into the stomach. So the reason I'm asking this, people at home are going to be thinking, okay, so colonoscopy, fine. That's the endoscopy part that I know. What are symptoms or reasons someone would come see one of the three of you, like, these are my symptoms, something's going on, I need some kind of endoscopy? So you were beautiful in talking about prevention and talking about catching something early. What are some symptoms that people at home might be thinking about? Yeah, I've had this rough, maybe cough, but I know it's not from my stomach, I know it's from my esophagus, I know it's from my throat. What are people complaining to you about when they come see you?
It's common, especially because of the diet and the love for Chile in our community.
The love for Chile in our community, I love that. That's so true.
We see a lot of people with recurrent heartburn. So sometimes they try medications over the counter and the symptoms are not improving. So sometimes, most of the time they ended, primary care physicians refer those patients to us. Is this patient needs an endoscopy or not? Not everybody with heartburn, of course, needs an open endoscopy. Most of the time, when we take a history and physical, it depends of some what we call risk factors. Is this patient having problems swallowing? Is this patient having blood in the stool? In this case, if we're assuming that it comes from an upper source, would be like black stools. Are you having weight loss? Do you have a family history of esophageal, stomach cancer? What is your age? Sometimes when it's older than 50, it's a good idea to take a look. Then what is your race? If you're a Caucasian,
Now, are we talking about screenings?
It's not such a thing as a screening for the upper. The only screening is lower. It's colonoscopy. So we screen everybody older than 45
so I'm thinking
or 50,
about upper
depending
body.
of the societies. In the upper, you have to have a symptom. It's not like you are normal.
Exactly. Okay.
For example, I'm from Venezuela. In one area of Venezuela, we're supposed to do a screening endoscopy because of the high incidence of stomach cancer.
Interesting.
Same thing is happening in Japan, in some area of Asia. It's such a high incidence of stomach cancer that they have screening upper endoscopy. It's not in our guidelines. We can practice that, but if the patient has some symptoms and some worrisome features, of course, an upper endoscopy is indicated.
So Dr. E, so I'm going to start talking this evening. On that note, and it's nice too to talk about, because different, just the way our genetics are made up, and my gosh, I look at these medical students and what they're learning in the world of genetics, and different types of populations have different predispositions, et cetera, et
Absolutely.
cetera, et cetera. So if we're talking about Venezuela, if we're talking about Japan, I did not realize that there are more incidents of stomach cancer.
Yep.
Number one, I'm asking you, because you're a future guy, right? Why might that be, if you know? And putting a screening in process, because that's a pretty big deal. Like our FDA versus an FDA type of a program in another country, what is it that gets to that point? For example, if we're talking about Venezuela or Japan, is there a reasoning that we know of at this point why certain groups are more predisposed to stomach cancers than others?
It is mainly genetics
Okay.
and how their genes are, and also their lifestyle and type of food.
Type of
So,
food is
yeah,
the big one that I'm thinking about.
yeah,
Okay.
Yeah, some studies said like certain type of food, spicy food, certain type of fish, their lifestyle in Japan may increase the risk of gastric cancer. So that's why they have very comprehensive screening program to have regular endoscopy, upper endoscopy, to look for cancer and look for abnormal mucosa. But here in U.S., there is, especially in white men, there is Barrett esophagus is more common.
Yes, that's one that I actually have a star on.
Yeah,
Yes, because I
absolutely.
know quite, in fact, just in my life, I know 3, and they're white males, come to think of it.
Yeah, absolutely.
That have an issue with esophageal, the Barrett's esophagus, also the ring. Is the Barrett's
Yeah.
esophagus that ring?
No, Barrett esophagus is change in the type of lining of the distal esophagus.
Okay.
In the last part of the esophagus. Esophagus is a tube connecting the mouth to the stomach.
Okay.
And there is specific lining. But when this lining change to certain type of lining, and we call it change to intestinal lining, this is what we are calling Barrett esophagus.
Okay.
And this, when people had Barrett esophagus, we should make sure this not people doesn't have dysplasia, because if they have dysplasia, they have high risk of cancer, esophageal cancer. And this is what this is one of the area which we can prevent by doing surveillance endoscopy and taking regular biopsy.
And that's beautifully explained. I think that's a nice segue too. We were talking about tumors at the end of the stomach, and Dr. Ladd, I'm going to talk with you and have the guys in the back. Gracie, I think that you're queuing up videos, so if we can queue up video number 1, and Dr. Ladd, if you can walk us through, maybe give us the setup first of why this surgery needed to be performed. I know we talked very briefly at the beginning of the show that there was a tumor at the end of the stomach, and then this video is of the surgery. What's happening here?
So here we're connecting the stomach to the loop of small intestine in a patient who has a tumor at the end of the stomach. The food is basically not passing from the stomach into the intestine. So by doing this procedure, we're creating a bridge between the stomach and the small intestine, and we're creating a pathway for the food to go through. What you see opening up there is a stent. It's a metal stent. It's like a metal tube that we use to connect the stomach, the cavity. Its function is to connect two surfaces. So what you're seeing here, we're done connecting it. Now we're putting a wire. We use X-ray to guide us and have an idea where the wire is going. This stent is now connecting the small intestine to the stomach. We're stretching it out. This is just one of the many tools we have in advanced endoscopy. And at the end of the procedure, there is a 15 millimeter, which is 1.5 centimeters opening where the food can actually go through. And what
Look
you
at
see
that,
there is
right.
small intestine.
Okay.
Normally, this procedure would have needed to be done surgically, and the patient needs to go to the OR. The problem is that sometimes these patients are too sick. They're probably at the end of their lives. The cancer is terminal. We're just trying to provide them with comfort for what's remaining of their life term. So this way we can save the patient going to the OR, saving the complications from the OR, infection, bleeding,
Exactly.
healing of the wounds. So that's why it's a very fulfilling feeling, I guess.
And
you
so,
wanna call it like
as
that.
we were watching that video, let's talk about what a person that's sitting in the OR can actually see. So you've got the the tube that's going in through the throat.
Yes.
So again, you're not looking at full-on open surgery. It's literally
No,
all going
we're
through.
not cutting the skin. Everything
very-
goes through natural orifices. We put it through the mouth. We aid ourselves with the ultrasound that Dr. Garcia was describing earlier. It's an ultrasound that helps us find the structures that are nearby the stomach. And once we find the area that we are looking for, then we intervene. And we also guide ourselves. So it's a combination of regular endoscopy, ultrasound, and X-ray, which is totally separate from a regular diagnostic colonoscopy or screening colonoscopy where you're only looking at the camera, you're only looking inside the colon. So this combines different disciplines, and that's why we collaborate closely with surgery, interventional radiology, because we all complement each other too, and sometimes we can help the patient much more rather than just working isolated by ourselves.
So Dr. Garcia, I'm going to ask you if you can expand a little bit on interventional radiology when you're looking at the team approach. And I love doing that with every one of our shows because everyone has similar situations that they're working with, but really it's very specific. So when you're looking at other issues that advanced endoscopy can help, what might those be, just off the top of your head? So I've got this laundry list of things. We were talking about IBS, we've got GERD that we do or do not have to talk about. I've already got 3 questions on GERD, believe it or not. I kind of figured they'd be coming in. GERD, meaning gastroesophageal reflux disease or disorder. Peptic ulcers might be one that we can talk a little bit about. So I'm just throwing some out that you see most commonly in your all-day, everyday work fashion.
I think the most common as an advanced endoscopy with an interest in endoscopic ultrasound that I see is people that for some reason they do a CT scan and they found they have a pancreatic cyst.
Okay.
So now everybody's freaking out because
Oh my gosh,
they
it's a
think that it
pancreatic
could
cyst,
be
right.
cancer. Sometimes it's the test is done by urgent cares and patients. Since pancreatic cancer is such a devastating disease, patients
Right.
come very anxious to us. So what we do is, first of all, we try to obtain all the images and records and see if this is in reality a pancreatic cyst, right? The advantage when we do endoscopic ultrasound is like we're going to be really close to the area of interest. The pancreas is just underneath the stomach. So we're going to be doing an ultrasound just next to the pancreas. It's completely different from other image modalities that you are far from the pancreas. So at the same time, when we do that image, our first task is make sure, is this a cyst or this is a solid lesion? When it's solid
Can
lesion...
you tell that while
yeah,
you're
absolutely.
in there?
They
You
look,
can.
They look
Okay.
completely different with ultrasound.
Okay.
So when it's a solid lesion, most of the time it's cancer. When it's a liquid lesion, then we need to try to put a name on that lesion. Is it the type of cyst that with time would become malignant and we need to do active surveillance of that cyst? Is it the type of cyst that probably no, everybody can chill out a little bit and then
Right.
you have a non-invasive image in 2-3 years just to you
So here
can
I'm
relax.
automatically thinking, just because of all the shows that we've done again on colonoscopies, I'm automatically thinking, okay, you see the cyst there, the advanced endoscopies there, are you at that point taking that cyst, or you said surveillance, right? So are we leaving it there? Is it something you have to decide right then and there?
Question, when we see a cyst, then the way that we put a name or a label of that cyst is two ways, right? First is the endosonographic appearance, how it look to us.
Okay.
It's have some worrisome features, it's connected to the pancreatic duct, has a thick wall, what's the size? And the second one, we put a needle inside. So everything through your mouth, with the ultrasound, we place a needle inside the cyst, and we suck the fluid. With this, we are not curing the cyst. It's just to do
Right.
extra analysis, including cytology, so we see the cells under the microscope, and we order tumor markers. Why? To try to identify if this is one of the cysts that we need to keep an eye. Answering
Right.
your question, we remove the cyst? No, that fluid that we remove is going to reaccumulate. In the past, research was done that we tried to inject alcohol and all that, and a lot of those patients were not a successful research. It was not done by us. It was done in the United States. Some of those patients developed cancer later on, even though the disease was eradicated. So the disease is not eradicated. However, if you determine that the cyst is, for example, an intrapapillary mucinous neoplasm and have some worrisome features, that the chances of this cyst becoming malignant is very high, you send that patient to surgery, and that patient get that portion of the pancreas resected because the chances of developing cancer is so high
Right.
that even a complicated surgery like a piece of pancreas removal is considered just to avoid that patient to develop cancer.
Okay. Nicely explained. I'm getting some questions here from the audience, and there's kind of kind of an overwhelming theme here. So I'm going to back up, and before I go specifically into these questions, so a lot of it is like, how do I know that I need to go and get an endoscopy? That's kind of what we're talking about, and then I'll get specific here. And Dr. E, I'm going to ask you that. I know we talked a little bit about symptoms, a little bit about risk factors, knowing your family history, etc. With normal screenings, it's different because it's like, you know what, the age of 50, get a colonoscopy. Now there's different countries that are doing different things. The Mexican diet's very different than the Middle America diet, which is very different than, you know, on the border of Canada diet. So when we're looking at that, I think Dr. Garcia said you have to be symptomatic before they come to see you. In general, what are people feeling as they see you? I feel like I've almost asked the exact same question earlier, but again, we're getting questions on that again. So is it a burning of the throat? We were talking about maybe that heartburn feeling, etc.
Yeah.
And then I'm going to go to some of these specifics because that actually will hammer 3 of these questions away.
Exactly. So there's certain symptoms and complaint people get it, so which can be simple or very serious. So when you become yellow or you see your skin yellow, or you feel like this is something serious. You
That
have to
jaundice look that people
exactly
get. Okay.
exactly. You have to
Okay.
see your doctor. If you have abdominal pain which is continuous and getting worse, and you are losing weight, this is something you need some workup. You need to see your doctor, which he can get some imaging, and if he find anything suspicious, he can send the patient to us.
Okay.
So if you get some acid reflux and you are not responding to over-counter medication, you may need to see your doctor.
So we're talking these guys, and I know these guys
Yeah.
that will down, you know, a bottle of Tums a day, and it's just not working. It's time to go see somebody.
Exactly.
Okay.
Because after a certain age, like we can say age of 50, if this symptoms is new for you, you may need an endoscopy. And now we have new modality to treat the reflux. So you may get one of these modalities and new medicine as well, which can help your reflux and get you.
And just out of
symptom-
curiosity, since you're talking about it, what are some of the new modalities? Because I feel like everyone in the world has heartburn, right?
Exactly.
We talk about there's 1,000 commercials about it. You look at a magazine, it's heartburn. So what are some of the new?
So absolutely. So it is one of my slides. If you can.
Okay,
show
if we go
It's
to the
the
video
last-
or the
last
excuse
slide.
me, not the videos, the slides. My
Yep.
apologies.
Yep. The slide number 3.
Slide number 3.
Exactly.
If we could go to slide number 3. Oh, good job, Gracie.
Yeah.
Okay, there
So,
we go.
so in this slide, you see the stomach, the healthy stomach. So there is always acid in the stomach, which increase after patient eat, and there is a sphincter which can prevent acid from going from the stomach up to the esophagus. When this sphincter become relaxed or incompetent, which is not working as should be, the acid go up. So nowadays there is a new modality called transoral incisionless fundoplication. So we
Say that slowly again. Sorry.
so
I know.
I know it is we call it TEF.
Just so yeah,
TEF.
it's kind of so
Transoral
transoral
incisionless
incisionless.
fundoplication.
That I can't even try. Okay.
Yeah. So in before there and still going, this procedure requires surgery. You create a new valve. Now we can do this by endoscopy, and this is the most recent advance in this area. And
So again, no surgery.
Yeah.
Post-op, not an issue. Something you can do. in
yeah,
an
so
office.
just people who want to get off medicine or who not responding to medicine, who can do this with this type by endoscopy. And also we collaborate with surgeon, and sometimes if the people have hiatal hernia, large hiatal hernia, they can repair the hernia, and we can do this by endoscopy to create a new valve.
So on that note, if you can describe to the audience what is a hiatal hernia? What is it? If you can physiologically describe in the
Sure.
body what's happening when somebody has that
Hiatal
type of
hernia, you know, as normal person who doesn't have hiatal hernia, the esophagus, all the esophagus in the chest, and all the stomach is below the diaphragm. So diaphragm separates the chest from the abdomen.
Okay.
So when part of the stomach goes up in the chest or go above the diaphragm, we call it hiatal hernia, because there is opening in the diaphragm which connects the esophagus to the stomach.
So it's a protrusion out
exactly,
of... Okay.
exactly,
Okay.
and this can worsen the reflux. And so many people has it without symptoms, but some people when they have it, they have acid reflux.
So I'm looking 5-10 years down the road. Is there an issue in the future that's dangerous with that hernia? I know that you can fix it here. Is it more of a comfort thing, or is it something that could...
So there is nothing dangerous unless there is symptoms.
Okay.
So many people has hiatal hernia, small hiatal hernia with no
Right.
symptoms. So I think we shouldn't do anything for it.
Okay.
Once a patient has symptoms, problem swallowing, or has feeling acid going up and cannot control it, I think this is a time we can repair it.
Okay.
So many people has it with no symptoms.
Nicely explained. Okay, Dr. Ladd, I would like very much to talk a little bit about ERCP. Number one, if you can explain what that is. I know we have a video on that. So this is the second video, Brenda. If you can cue that up. We're not quite ready to go there yet, but explain what ERCP
ERCP
is.
stands for endoscopic retrograde cholangiopancreatography.
Say that slow too. Dr. Garcia even laughed. She said it way too fast.
Endoscopic retrograde cholangiopancreatography.
Okay.
What we do is we get the camera down into the beginning of the small intestine, and we access the bile duct, the biliary tree, which is the duct that drains the liver into the intestine to put all the bile that you need to digest your food.
Gotcha.
People
Okay.
get stones form in that duct. People get tumors in that duct. People sometimes bleed from that, so that the procedure allows us to access the biliary tree and intervene on it. The most common reason, I would say, is probably stones, and that's how people know if they have stones. They're going to have pain, fever, they can get jaundice, they can turn yellow, like Dr. Hanafi said. Those are probably the most common symptoms. Incidence of stones in this area is very, very high, so people should think about that. Gallstone is not the same as having a stone in a gallbladder. The gallbladder is like a reservoir of bile. That's where most of the stones form, but sometimes one of those stones fall out of the gallbladder and get stuck in the duct. When it gets stuck in the duct, it can give you jaundice, or it can give you pancreatitis, because the pancreas drains in the same conduct that drains where the bile is draining. So if you get pancreatitis, you're going to know it. Pancreatitis is severe abdominal pain. You cannot hold anything down. You go to the hospital. That's
And when you
not
have
something
gallbladder issues too, I just feel like in the last 2 years, I know 2 people and a dog, my daughter's dog, literally had their gallbladder removed because it was causing all kinds of crazy issues. And I feel like I haven't really heard about that earlier, but the incidence of removing the gallbladder, super simple, easy, fixed so many things at that time too. I personally have 2 polyps in my gallbladder, active surveillance, I think you said earlier. So they're just watching them, they're not doing anything, they're just hanging out, having a good time, but there's
Most
no
of the
symptoms.
time you don't need to do anything about them.
Okay, so when you're talking about, so this whole area, I almost wish we had a graphic of this whole area of the body. So when you're looking at the pancreas, the gallbladder, how do they relate and what are their functions? Because you can take a gallbladder out, you have to maybe minimize or just adjust your diet a little bit, but talk about the relation of all these organs with one another and how you do, and again, I know we have a ERCP video that we've got showing up too, but just explain what the functions are in the body in those areas.
So the functions of the liver are, to describe the whole list of functions of the liver is beyond the scope of the show, but just focusing on the digestive part of what the liver does, it makes bile, which is a substance that helps you absorb nutrients. This combines in the small intestine, it gets mixed with the pancreatic juice. The pancreatic juice contains enzymes that help you digest food as well. And then outside of that, the pancreas also has the main function of producing insulin, which is what helps you keep your glucose and your sugar under control in the body. So what we deal with most of the time is problems in the digestive aspect of the liver and the pancreas. If you have diabetes, you go to an endocrinologist or a general medicine person. We don't really treat that anymore.
Okay.
Speaking of the gallstones, When you have gallstones, cholecystitis, I mean, removing the gallbladder is probably one of the most common surgeries that are done worldwide.
Yeah, I feel like I hear about it every
However,
day now.
sometimes patients are not good candidates for surgery because they're comorbidities, because they're not well, they're malnourished, or they have some other issues going on. Endoscopic ultrasound provides us a way of treating people who may have gallstones and remove them in a way that do not require surgery. So we basically do the same thing that you saw in the video earlier. We put that stent, that metal tube that we connect your gallbladder to the small intestine, and from that point on, we get our camera inside the gallbladder and we remove the stones, and without the need of surgery. Now, that is not necessarily applicable for
I feel like
everybody.
that's so tiny. That's amazing
Yeah.
to me that you can do that.
Yeah, it's
Okay.
not for everybody. I'm
Yeah.
not saying everyone should have it, but it is definitely an option, specifically for patients who are gonna do poorly after a surgery. This is a very good option for them. I don't know if we have the video.
Yeah, so if
but-
we have the video number 2 that's queued up at ERCP, so
this
here it is
the-
right now.
This
Yeah.
this is the other video. This is actually
Oh.
a polyp of the colon. So this polyp in the past would have probably gone to surgery. It's a very large polyp at the very end of the colon, which is the rectum. So what we're doing here is an endoscopic mucosal resection. That means we start injecting liquid inside the polyp to separate it from the rest of the wall of the colon. The colon has different layers.
Okay.
And by separating the layers, it allows you to intervene on the polyp in a safer way so that you don't create a hole in the colon. So what you're seeing here, we're lifting it, we're injecting it with a solution to help us separate it, and then we're gonna start cutting. I think at this point we already started cutting. Yeah, we're cutting. This is how we start cutting piece by piece. Ideally, you want to remove the whole thing in one piece.
Right.
But sometimes they're too big, and you need to do it in what we call a piecemeal or different pieces. However, this is the end of the procedure. At the end, you see there's no polyp left. And again, this is a patient that probably would have gone to surgery if we didn't have the resources to treat him this way.
Interesting. Right.
So
It's so beautiful. Dr. Garcia's like, it's so beautiful.
nowadays,
But I can see that too because,
said very good job.
yeah, when you look at, there's really no wound per se. I mean, you see
Yeah.
it there, but there's no bleeding. Is there a cauterization? Has that
yeah,
already
we cauterize.
occurred?
When we cut,
Okay.
we cauterize at the same time. Sometimes we
I
need to
see.
cauterize blood vessels that may bleed. The patient goes home the same day. They don't really have to stay in the hospital. There's no recovery. They go back to their normal life the following day. Now, speaking about the size of the polyp, one of the procedures we're going to start doing this year is removing large polyps like that in one single piece, which requires a lot more time, different kind of devices, different technique. But the whole point of doing it that way is that sometimes during the cutting it into pieces that you saw there, microscopic pieces of the polyp might have been missed, and this procedure allows you to cut the whole thing out. Actually, it started in Japan. The Japanese are the ones that lead the way in these kind of procedures. They started doing it in small lesions. There is still in theory some size limitations about how big a polyp needs to be for you to remove it. But technically, I mean, in reality, people are tackling gigantic polyps. I mean, I can show you videos.
Right, and
of
I'm
it.
thinking to myself too, I keep saying old days, what does that mean? So 5 years ago, it's like if you have a really large polyp or several in an area, you would actually have to cut into the colon and then cut a piece of the colon out,
Yeah.
resect it, sew them together, so this is something that we are now with advanced endoscopy at UMC able to prevent. Am I
And it's
correct
interesting
in
that you
saying
mentioned.
that?
Yes.
Okay.
Yes, we have the best tools. We have the best team. Actually, the unit at UMC is the only unit in the region that has 100% of its staff certified to be a GI specialist. So our nurses are certified, our technicians are certified. We all had our own training, and we're happy and glad to offer that service to the population here. One last thing that I wanted to mention is regarding removing these large lesions. We can do that in the stomach. We can do that in the esophagus. We can do that in the colon. There are certain criteria, obviously, that we need to meet in order. Not everybody is going to be a candidate for that, but if
So tell us what that criteria is. Like,
yeah,
who
so
is a
we look
candidate,
we
who
look
is
at
not
the
a candidate?
morphology. We look at the shape of the polyp.
Okay.
Certain aspects of the surface of the polyp that we evaluate with the camera. We look at the margins, the location of it. Some locations are harder than others. This one was technically easy, I would say, because it's right at the rectum. It doesn't really require that much. You're only introducing about 15 centimeters of the scope, but when you have to do a procedure removal that is far up in the colon, in the cecum, it gets a little trickier because you have to maneuver things differently. Yeah, so, but this is something that, again, people should be aware of, because if you have a polyp, a large polyp, and surgery is offered, I think it would be worth them consulting over here to see if the polyp can be actually removed endoscopically, and we can actually save them a surgery. Not every polyp is done that way. Some polyps will definitely need to have to go to surgery, but for the most part, I would say at least 70% of those large polyps we're able to remove endoscopically.
So pardon my ignorance, because I feel like I should know this, but so that particular polyp that was removed in the video that we just saw, is that a one polyp in that one colon incidence? Is that an individual who is apt to develop more polyps in the future? For example, I know sometimes like, oh yeah, this guy has 10 polyps in there, so we had to go in and take all of them out. Beautifully, they were benign, but every now and again there's 2 or 3 that are not benign. How in general is that developed in everyone's colon? I mean, is there a person that if you're gonna have a malignant polyp, are you apt to have more later in life? How does that work? Because I know when the screening goes, you go in, you have a colonoscopy, everything's clean, you're good for 10 years. If you have a polyp and it's still clean, you still need to go every 5 years because it's still a polyp that was there. Describe a little bit about that. When people at home are listening to this, it's like, okay, I had something removed 2 years ago, what does that mean now?
For the most part, every cancer or every polyp that we find in a polyp is called sporadic tumors or sporadic polyps. That means it happens to everyone. There is no particular reason why they happen. It might be genetics, it might be age, it might be the diet. At this point, we don't really know exactly what makes polyps grow or what makes cancer come up. Although we have risk factors, but some people have risk factors and they never develop them. Some others never have the risk factors and they end up with a tumor. Now, there are certain conditions that predispose you to certain kind of polyps and whether or not they're going to come back. Those are genetic conditions that need to be tested for at your doctor's office. And if you do have one of those mutations, which are mutations with genetic mutations that predispose you to have certain kind of polyps, some of those conditions require you to remove your colon at a certain age, regardless of whether you have polyps or not, because we know from the experience and from the research that is done that these people are going to end up developing a tumor sometime sooner or later. So there are specifically to answer your question, there are conditions that are going to predispose you to have many polyps throughout your life.
Right.
And not all of them need to be removed. Some of them have to, some of them don't. And then for genetic conditions, there's really no cure, right? You're born with it. There's nothing we can do about it. And that's why it's important to know your family history, because that can give you a hint about whether or not you're going to be at risk.
Very interesting. This is a show that needs to have a lot more time to it. Believe it or not, we have 15 minutes to go. So I'm going to shoot out, I don't know if there's a Jeopardy speed round or something like that, but I'm going to shoot out some questions here. This is all that we have. This is the disclaimer to the audience. This is all that we have for you all to go on, answer them to the best of your ability. There was a disclaimer at the beginning of the show saying nobody can be sued for giving the wrong answer. Just saying.
Do we have to answer in a form of a question?
Yeah, well, you never know. This is a quick one. Is it possible, as we talked a little bit about this, is it possible to fix a hiatal hernia with endoscopy in a 90-year-old patient with GERD? I'm throwing that out to anybody who wants it. Again, this is all we have. Dr. E.
It all depends on the size of the hernia.
Okay.
So first we need to do endoscopy to evaluate the size of the hernia and evaluate the esophagus. So we cannot say it is possible or not possible unless we do endoscopy first.
But the nice thing is there is a possibility if you were
exactly.
able to check
If it is less than 2 centimeters.
This one's a loaded one. I don't know how quickly we can answer this, but this was going to come up. How do you differentiate IBS symptoms, so irritable bowel symptoms, from colon cancer? And again, when should I be worried? It's several of the questions are similar to that. Who wants to take that? Dr. Garcia.
It depends on your age group. IBS sometimes is what we call a diagnosis of exclusion, meaning that sometimes we already exclude that you have colon cancer, unless you are somebody that is 18, 20 years old with classic symptoms of irritable bowel syndrome. So in those particular cases, probably you will need a colonoscopy.
Okay.
Now, if you are somebody a little bit older, part of your workup in order to label you as an IBS is going to be a screening. So we know that you don't have colon cancer.
Okay. Another question here from the audience. If a patient is taking medications for GERD, Dr. E, you talked about this earlier, if a patient is taking medications for GERD and they are no longer working, what does this mean? What can I do? I know you touched base on it earlier.
Absolutely.
Maybe throw it in there again real quick.
So it means maybe we need to do endoscopy as well to see what's the status of her stomach. Maybe she has inflammation in her esophagus. So we need to do endoscopy at that point if she's not responding to medication. And based on the endoscopy, we'll decide if we need to do any any intervention to increase or create a new valve for her.
So bottom line, you got to get in there and find
We
out.
have to work on her diet,
Yeah.
his diet too.
Yeah. You know, diet's such a big thing. I mean, we feel like we hear about it all the time and people just blow it off, but it's a big deal. So I'm glad that you
Absolutely,
brought that
yeah.
up.
We are what we eat.
Yeah, we are what we eat, right? I agree. We are what we ingest in all kinds of ways, mentally as well. Question here, I'm not sure what this is relating to, but what is the youngest age a patient can be when they have an endoscopy? I'd imagine there isn't a youngest
We
age.
can do endoscopy in kids.
Newborn,
Yeah.
yeah,
There's
if there's
no
an
age
issue or a
limit for
reason
it.
for it. I'm going to go here. Oy. If my gallbladder was removed 20 years ago and I recently started developing a lot of nausea lasting for more than 6 hours plus, followed by vomiting just bile, is this something that I should be worried about? So again, we talked a little bit about gallbladder removal. This was 20 years ago, so this is may or may not be related. Anybody want to take this
At
one?
this point,
Dr.
this is
Ladd?
not gallbladder related, but if the patient is vomiting the way he or she is describing, he needs to go see the doctor because there are many things that can give you those kind of symptoms.
Right,
But
agreed.
unless we examine him or her, we do some imaging, x-rays, endoscopy, that way we can give him or her an accurate diagnosis.
Another question from the audience, and this is me, I'm a polyp girl, so do gallbladder polyps become malignant? How soon, and do they become confused with gallstones, is a question from the audience. Who wants that one?
They look
Dr.
different
Garcia?
than gallstones, so usually you are not going to confuse them. It's very uncommon for them to become malignant unless they are bigger than 10 millimeters in size.
Okay.
So usually unless they are 10 millimeters in size or you have symptoms like pain in this area that we call rhyoperquirent pain, you don't remove the gallbladder.
Okay, nicely said. We're at the 10-minute mark, so we have questions still, but what I want to do is respect and honor the fact that you all drove all the way here. You all are very busy, on call, etc. I would like to see, and Dr. Ladd, I'm going to start with you. Is there something that we really need to focus on tonight before the show ends that we didn't get to yet? I know that we didn't get to the ERCP video. We can still do that. But something you want to talk about, because I know sometimes the end of the show comes in and it's like, oh man, I didn't get to say A, B, and C. Anything for you?
I think I would like to emphasize and let the people know that we are constantly advancing in the procedures that we do and the treatment options that we can offer. And if patients, for the most part, they come to us once they have already seen a gastroenterologist because they found something that needs to be treated, and at that point they get referred to us. However, we want people to be aware that things that used to be surgical problems may not necessarily be anymore. So they need to ask questions to their physician, to their primary care, to their gastroenterologist, and even if they have a diagnosis already established and they have been given a treatment option, it's worth consulting somebody else. I'm talking about if it is GI related, right? It's also worth consulting a therapeutic endoscopist because most of the time we will be able to offer them an alternative treatment option, considering all the other factors that we need to put into play. But that would be my closing remarks. So just ask questions.
Don't be shy, ask.
Be aware that there are a lot of things that we can do now that we were not able to do 20, let alone 5 years ago. So
Right.
it's important for people to know that.
And Dr. E, I know that before the show started, we were talking about all the stuff that's on the horizon. So I don't know if that's something you want to talk about right now too, but I'm looking at you. It's like
Yeah.
you're the kid on the panel right now, right? That's your job. But what would you like to get across?
So in near future, we're gonna start 2 procedures in University Medical Center. One of them called POM, which we use this endoscopic procedure. We treat achalasia. Achalasia is a problem in the muscles of the esophagus, which is no peristalsis, and problem in the sphincter, which is not relaxing. So
It's not relaxing, so
Yeah.
it's kind of almost like there's a
Yeah,
spasm in the
exactly,
esophagus.
exactly.
All right, my ex-husband had that, and it was very scary when it was happening to
Yeah.
him. So I'm very interested in that. I know we don't have a lot of time, but
Yeah. So this is a relatively new procedure in U.S. and it is. In this, we treat instead of doing surgery for this procedure, we do endoscopy. And if you show the slides, there is.
we can go to slide
Yeah, we go by slide one.
slide number 1, please,
Yeah.
Brenda. Thank you.
By endoscopy, we go through the mouse. We go in between the layer of the esophagus, and try to make a tunnel, and then we cut the muscle, which is spastic and which is not contracting. So we cut this muscle and close the entry site, and this patient can go home same day or the next day without no open surgery. This is treatment for achalasia. And there is another procedure we're going to start also soon in University Medical Center called GPOM. We treat gastroparesis the same fashion. This is slide number 2. We go in between the layer of the stomach, and we try to do a tunnel, and we cut the muscle which is spastic at the exit of the stomach. So this procedure have been done in other big institution, but it has not been offered in El Paso yet. So in near future, this is going to be available in our center.
And this is also done by advanced endoscopy or endoscopy
Absolutely, yep.
as well. So
Yeah.
again, we're still looking at very minimal
Yeah.
recovery time. It's
Exactly.
okay.
Yeah,
Very nice.
patient can go home same day or the next day, and there is no incision in the skin. Everything is through the mouse.
And if there were, it seems like there would be very minimal complications, but that's always a question as well. Complications of endoscopy, and maybe we can talk about actually what's great about endoscopy type surgeries. I know it's the wrong word to use, versus traditional surgeries. Let's talk about the pros and cons, if there are any cons.
Yeah, absolutely. There is nothing without risk. So
Right, good point.
there is always
There's nothing without risk.
Yeah, there is risk and benefit, but our rule to try to minimize the risk as much as we can. So we take all our precaution to minimize the risk. And if the main risk of this procedure is like infection, bleeding, perforation, and if any of this happen, we always have treatment for that. And we always, the beauty about advanced endoscopy and about UMC as a center, we work together. We work closely with surgeons, with radiology, with oncology. We work all as one team. We call it multidisciplinary approach to any problem. So this is what makes UMC unique.
Nice. Very nicely explained. I appreciate that. And it's nice to always see what's coming up on the horizon. Dr. Garcia, how about you? When I say that, like anything that you want to expand on or that we haven't touched base on yet?
Yeah, I would like to emphasize that a few years ago, none of these procedures were done in town, and patients that need these need to travel to Dallas, San Antonio, or Phoenix. In 2013, University Medical Center, Texas Tech, and one of our mentors, Dr. Mohammed Othman, were the pioneers doing this in town. Has been 7 years where we'll keep growing. Now it's 3 of us doing procedures here. We have a state-of-the-art unit. We're the only unit in town that got the certification by the American Society of Gastrointestinal Endoscopy as a center of excellence. We have an amazing team of nurses and tech that are watching us at home and
Yeah.
make our life
They'll
easier
appreciate the shout out. You'll hear about that tomorrow.
every day. And they're very skilled, some of them with more than 7 years of experience in advanced endoscopy and even more in regular endoscopy. So what make us the referral center for the region and for sure the best endoscopy in town.
And it's nice, again, when there's a team approach. And again, I know Dr. Ladd has been on several times, and I always learn something new from you, too. We have a whopping 4 minutes, which actually is longer and shorter, depending on how you look at it. Question here, after colonoscopy with a polyp removal, if the biopsy of the polyps is negative, is there a chance that I might still get cancer in the future? So again, this is that where I was talking about screening. If there is a polyp, it is negative, but because there was a polyp, is there a screening measure like 3 years later, 5 years later, Dr.
The definition
Garcia?
of negative is like if the polyp is an adenoma, you need another colonoscopy in 5 to 10 years, assuming that this polyp was not bigger than 10 millimeters. If the polyp, what they call negative, is a hyperplastic polyp, you need another colonoscopy in 10 years. Answering the question, is there a chance? there is always a chance. Colonoscopy is not a perfect test. It's not that
Exactly.
we don't miss any polyps, but chances, I would say, are very, very low.
And also, I would add to Dr. Garcia, if patient has family history of colon cancer, first
As he
degree
said.
relative, he should have close surveillance on colonoscopy.
Okay. And Dr. Ladd, I'm going to throw this one your way. Gastroparesis and working in conjunction with the vagus nerve and gut. Question from the audience. What can be done about that? Geez, I know I'm throwing that one at you, yeah.
What Dr. El-Hanafi just mentioned is this G-POEM. POEM is the acronym for oral endoscopic myotomy.
Gotcha. Okay.
What we do is, what used to be done in the past is, you go to this, the OR, they cut you open, and then they cut the muscle that connects the small intestine to the stomach, because that's the one that is tight. It's a ring that needs to open for the food to go through. People with gastroparesis, in those kind of patients, the ring does not open, so the food just gets stuck. So what we do is we go in endoscopically, we cut the muscle so that the food has a pathway now to go by again. Again, this procedure was not available 10 years ago. This is fairly new.
Yeah, I mean, 10 years
And-
ago was yesterday. You know, if we're really looking
Right,
at it,
right,
that's how we're.
yeah.
And again, I look at you. Can I ask you how old you are? I'm 52. So I feel like
No,
if
no,
I'm allowed
I'm
to
40.
say that, you're 40?
Yeah.
Dude, you look like you're 28 or something. So you're the kid, and I'd love to have, and it's nice to have veterans on, it's nice to have the young ones on, and it's nice to have this little girl who's in I shouldn't call her a girl, but third year in medical school. What's going to be going on in 5 years from now is amazing to me. We don't have really enough time for another big question. This one does long-term use of PPIs. What does that even mean? Increased risk of gastric cancers. What's a PPI?
PPI is proton pump inhibitor. Is the most overused medication in the United States. It's a very safe medication as a general rule. Since it's the most overused medication, of course, it's going to have some bad press. Overall, it's very safe.
Okay.
Regarding the question, risk of gastric cancer because of PPI, I would say 0.
0. Nicely said. Okay, that gives us a whole minute left. So I want to say again, Dr. El-Hanafi, thank you so
Dr.
much for
Torre.
being here. I had to
Thank
go
you.
with you first because Dr. Garcia is easy. Again, you say the accent kind of confuses people because Venezuelan accent versus Spanish accent. And then Dr. Ladd, again, it's always been a pleasure having you on. Again, we learned so much. We've been
Likewise,
talking
thank
about
you.
advanced endoscopy continues to improve, and specifically, these are 3 docs that practice at the University Medical Center of El Paso. There's a lot of procedures that are going on there, a lot of advances that are going on there. If you want to watch the show again, because I know sometimes it goes by so fast, you can do that in 2 different places. You can do that at pbselpaso.org, and then also at the El Paso County Medical Society webpage, and that is a .com. I'm Catherine Berg, and you have been watching the El Paso Physician. Stay tuned. We've got several shows coming up this month. And again, El Paso Physician right here on PBS El Paso. Good night. That's where they count us down.